Thank you all so much. And thanks for inviting me and having me. And thanks for that kind introduction, Brandon. So I actually was reflecting on with Tracy actually and Michelle about how I participated in a hackathon in a district hall in Boston, maybe 4 or 5 years ago. And I was part of 2 teams, SIF on a boat, which modeled itself after Ireland doing abortions on a boat to create a safe space on the ocean. So that was an interesting kind of policy hack. And another one called Matmobile, which basically was mobile buprenorphine, which really does happen now and is not that novel an idea, but at the time we were like, that's a great idea. Like you could just do Matmobile, so MOUD on a van. So that actually was the coalescence of what became this advocacy group in Massachusetts called SIFMA Now, which I met Aubrey Esters, who was like a fierce advocate, who I would like to donate a lot of my talk to in her memory, but she really pushed me as a clinician, as a friend, and I just met wonderful people, and those relationships lasted for years. So I hope this happens for you as well. So I called this, What Can We Do? And I think Tracy and Brandon have outlined, and hopefully I'll kind of help you think through some of how I think about what we can do for people who use drugs at this moment. And so excited that you're joining us from around the country. So a little bit about National Harm Reduction Coalition is we are a national organization. We sponsor a big conference every 2 years that sadly was delayed by COVID last year, and it was meant to be in Puerto Rico. We provide policy training, technical assistance, and a lot of resources that you might have encountered on our website. I have no disclosures. These statistics are grim, and Brandon presented some of the ones locally here in Rhode Island, but the national statistics are also grim. And we're basically in this steady climb, this unending steady climb. And it's not only opioids, while this is an opioid hackathon, polysubstance use, many other substances as well are really also causing increases in death. This is data from the CDC, Overdose Data to Action, that shows in the last year really states where drug overdoses and emergency department visits were going up. So there's a lot of regional and statewide changes as well that are important to note. Another thing that's really critical, and this has been going on for a long time, so this is not anything necessarily new, but racial and ethnic disparities in overdose deaths. So this has been really disproportionately affecting Blacks and Hispanics, and that these numbers continue. So I'm hoping that there's ways that we can think about incorporating these ways that we can hack some of these persistent and longstanding inequalities in health justice. I have some slides also about methamphetamines and cocaine, because even in the absence of opioids, we are seeing increases in deaths. And I think for many people, including people who use stimulants, this is also sort of a health justice issue. And I want us to not be so opioid centric, while we know that opioids are a primary driver, to pay attention to people who use stimulants, including people that smoke stimulants. So cocaine as well. And I'll do a little grounding for what is harm reduction if this is the first time that you're learning about it. And at National Harm Reduction Coalition, we've kind of defined it in a broad, sweeping philosophical term, and also a practical sort of set of strategies. And when I talk to doctors or clinicians, we often talk about the sort of practical strategies, but when we talk to people in the movement, we really want to say, like, this is a movement, and we really want to shift power and resources to people vulnerable to structural violence. Like, we really want to involve people who use drugs. We really want to not focus only on naloxone, and we don't really just want to focus on syringes, but we really want to liberate people to, we want to equip people with their basic needs, and we want people to be able to flourish and not only survive, but flourish and thrive. So that's part of that, that broad sweeping movement. And then when I'm talking to interns at the hospital, we talk about, okay, making sure, like, how do you prescribe syringes? How do you actually get people what they need if you're in the moment where you can actually help them? So those definitions, I'll put those there for you. And it's a common misconception for many people when I'm talking about what harm reduction is and the services that we have in the little h, little r category, to really think like, oh, it's syringes, or oh, it's naloxone. And we really think broadly about harm reduction as a wide variety of services, including drug checking, housing first. You guys are paving the path for overdose prevention centers, and even pharmacy access, which is just so critical. If you have a pharmacist who has a standing order for naloxone, or who can sell you syringes. Some pharmacists are working on fentanyl test strip training. I mean, really pharmacists can hold the key to the kingdom. So really thinking about harm reduction across a variety of spaces and thinking about service harm reduction as all of these different components. Even low barrier medication where people don't cut you off if you've used intermittently and you only take your medication a couple times a week, like that I would consider a harm reduction approach. So principles of harm reduction, I won't necessarily read them off for you, but they often get waylaid, and they're very pragmatic, and they put people who use drugs first. They promote health and dignity, and they're just very pragmatic and realistic. Like, what do you need? How can I help keep you safe, healthy, happy, thriving? And how can you be involved in that process? So one of the models that we use is risk set setting, and you might have heard it as drug set setting. And I thought this might be useful to think about as a theoretical framework for you to think about hacking any of these domains. So for example, the risk might be injection drug use, sex work, whatever we're discussing. The mindset is the set part is the attitude, the expectations that people have, how they're feeling. And the setting is this physical and social environment in which people can use. And, setting, for example, the most obvious example might be, you're in a Dunkin' Donuts bathroom, or you're in a Rhode Island harm reduction center, right? You're in a place that is, you don't have time, you're rushing, you're in opioid withdrawal, you're locked, people are knocking on the door, or you're in a place where you have access to supplies to clean your skin, to take your time, to find a vein if you need a vein finder, or if you need warm water to bring up a vein, right? I mean, the setting, thinking about decreasing your risk for infection, for abscess, if we can intervene on any of these particular things to make any of this safer, I think that would be really, really wonderful. You're thinking about the risk setting, so drug checking might fall into the category of the risk setting. So people actually know with a mass spectrometer what they're actually using, like that is knowledge, that's empowerment, and that ultimately I think leads to safety. So, the past year, we've seen sort of attacks and losses in the harm reduction field around the country. This is Oasis in Atlantic City. This is Austin, Indiana, and this is West Virginia. So I think it's also really important as we think about policy hacks, or thinking about why are we losing ground? Why in places where there were literally Indiana, Scott County, Indiana was the birth of, HCV and HIV clusters and epidemics that, were in fear of recreating, and that is becoming eroded. So what is going on in our political environment today, in our socio-political environment today, in our communities that are often based on politics of fear, I would posit, that are eroding these evidence-based services. And the New Jersey testimony, for example, it didn't really, like 200 people testified in favor of the syringe service program. And like the board, still evicted them, or you know what I mean? And so it's like, we believe in evidence, but do people believe in like how do we change hearts and minds, right? And so as people who care about data, as people who care about evidence, how do we also like talk about hearts and minds and affect and emotion and feeling, and how do we recognize that that leads to policy, and so I don't have the answers, but I have kind of watched, sort of syringe service programs struggle and or go underground as a result of some of these policies. I'd also like to talk about hacking stigma. So if we can think about ways that we can address some of the really harmful ways that stigma works, both at a internal level, at a community level, at a larger cultural discourse level. As an anthropologist, I think there's a lot of work that we can do in this area. So this is an example of New York City, where I lived for several years. And during COVID, says the ugly side of New York's outdoor dining renaissance. During COVID, there was a lot of displacement of people. There was a particular hotel that became the sort of vanguard of some neighbors' ire. It's called the Lucerne Hotel in the Upper West Side, and there was a group that basically was like, we do not want people who are homeless, who are being housed in COVID hotels, to be in our neighborhood. We don't want to have to watch our kids go into Walgreens and have our kids, see our kids, have our kids see someone being revived with naloxone. We don't want people, ruining the landscape of our neighborhood. I was called into a group that formed in response called Love and Safety, that was trying to welcome the people who moved to the Lucerne, who really felt happy in that in their hotel, and they really felt housed and happy for the first time, and they were able to access their healthcare services from there. And so, but this was very controversial. Also known sometimes as, the associated with stigma is the term NIMBYISM, or not in my backyard. And that's a really important thing whether we're thinking about methadone clinics, whether we're thinking about zoning, whether we're thinking about harm reduction centers. We're thinking about what do neighborhoods want and need, what do the most structurally vulnerable need and want. And this was a campaign that we had at Harm Reduction Coalition and the San Francisco Department of Public Health. And it was a campaign that was revolutionary, or very simple in some ways, where it featured people who use drugs, not necessarily people in recovery. It featured real people. It featured people taking care, it showed people taking care of each other. And it was with a lot of harm reduction strategies and techniques that for you all, like going slow and testing the drugs, like making sure you're using with someone else, or carrying naloxone, knowing how to use it. And this campaign was actually quite controversial. And city alders and things, there was a lot of vitriol. There was particular attacks on some of the images of people who were Black, Indigenous people of color who were featured in it, where Black African Americans were like, I don't want to see like a picture of a Black man, telling me to use a harm reduction strategy. And I find that offensive. And there were other images, which I don't have here, but there were images of people in like LGBTQ, trans people who were partying, people who were like, test your drugs. And those were very offensive to many people in the community. They were like, this condones drug use, like you're making it look cool. You're making it look like seductive, like fun. And it really was very, the responses were actually very telling and very interesting. And I think that as a phenomenon, these are things that, so the campaign ultimately was taken down. Many billboards were taken down, and even in like kind of a city that we think is very politically liberal, like San Francisco, it wasn't very quote unquote successful. So we know that during COVID, things have only gotten worse. At the beginning of COVID, we put out resources, and I was scrambling at the time where I was like, this is going to be terrible. This is going to be terrible for people who use drugs. Like I was expecting like a cliff, and so many of the deaths, that, I think the CDC just revised the numbers to 97,000. So like this was really bad. The stress, the isolation, the trauma, the access, the boredom. I mean, all of those things led to increased use. At the hospital, we're seeing many more people in acute liver failure. We're seeing way more alcohol use disorder, people who otherwise would have been employed and have sort of a structure, really sort of having catastrophic consequences in their lives. And so we put out a variety of resources. And so thinking about COVID being like the new normal, and we had a world that was pre-COVID, and we're moving into like a COVID, a life with COVID, where it's going to be endemic. Like we really need to think about how you guys can hack, how we all can think about this new reality and grapple with some of the changes that are probably going to be permanent. I remember people asking me, I'm homeless, and I'm showering in a bathroom. So if I use that like hand blower to dry off my hands, will that spread COVID? If I'm doing this sex work thing, will that spread COVID? I had no idea. We all had no idea, right? I was just not guessing, but like doing the best I could. It was really common. I was just trying to use common sense. We really didn't know how COVID was transmitted. This was in March of 2020. So I love this slide. This is a slide from New York State Department of Health, and we're always like, how did we even like get this through our like state health department? Because it's secretly really cool for things that state health departments do. And so if you think about all of these different domains, finding a buddy or seeking help during a mental health crisis, finding a safe space, checking your drugs, managing your use, polysubstance use, using multiple drugs at once, like all of these domains are places where you can imagine there being certain hacks. How do people even find like a syringe service program? Like how do people even know where one is? So there's a lot of things, safety planning. And I really like this scheme that Tommy Brothers and his co-authors used in a recent paper on injection and injection-related infections. And I like this scheme just because it takes the emphasis not necessarily on the individual behavior, which as clinicians, we often focus a lot on, which is like, okay, well, did you like use an alcohol pad before you did an injection? And, did you use naloxone? But we really going into these like micro environmental and macro environmental factors that have huge force, have a huge pull on if you're able to use an alcohol pad, if you're able to access naloxone, if you were able to access buprenorphine or methadone. And so I think I wanted you to think about these schema and to be ambitious in the hackathon and think about, okay, housing. So what would I do? How would I like create a one-stop shop that has housing, healthcare, everything that people could possibly want to need in a one, a one facility, for example, or like what, the criminalization of drug use. So I get called about states where fentanyl test strips are not legal. And they're like, so how could I hack that? Or, how could I get people, safe supply or things like that. So it takes the focus away from individual behavior per se, and I want you to think more broadly. Certainly individual behavior is an important factor, but also what else can we do on the outside? And again, this schema for skin and soft tissue bacterial fungal infections, and thinking about, things like previous negative healthcare experiences. Many times I talk to clinicians and I say, okay, so I want to improve the care for people that come into the methadone clinic. How do they feel like accepted, loved? How do I take care of their diabetes? All these other things. But if I actually worry about people who I get phone calls from people in Oklahoma who I say, I have an abscess on my breast, I'm injecting, I have kids, I would rather die than go into a hospital because my child will be taken away from me. What should I do? I get those calls. And so how do we hack those systems that are like of structural racism, surveillance, social control? Like I worry about people that would rather die and do die because they don't want to interact with me. They don't want to come to me. They don't want to come to us because of things that have imprinted on them. So how do we hack those? How do we prevent those things from happening? Policies and laws governing pregnancy and drug use, for example, is, so mothers, what do I do for mothers, people, parents who are using chaotically? And, racism is a really important lens as well, so there's when we do harm reduction training for community health workers or other people, community-based organizations, there's an article that we use which says carrying naloxone while Black. And it's like, I will not carry that in Philly because I already am criminalized for being Black. And I do not want to have anything that looks like drug, quote unquote, paraphernalia on me, even if I could save my friend's life and I understand what it's for, I will not carry it, and so how do we think about, how do we grapple with sort of the structural racism, segregation, systems of surveillance and social control? So what keeps me up at night? And these are a lot of questions. These are a lot of things. And I'm not sure, hopefully you guys will think of some of the solutions. Okay, this is page one of 2. How can we prevent non-fatal or fatal overdoses? And the reason I say this, non-fatal too, is because non-fatal overdoses are scary. They are scary, they are traumatic. There are, groups of people who reverse overdoses because it's so traumatic. And there is significant, confusion, there's anger, there's all kinds of feelings that people have when they're involved in reversing an overdose. And it can be confusing and scary for people who survive them as well. How can we prevent infections? How can we address healing and these problems of grief, trauma, unending overdoses for people who use drugs? The basic problem of social isolation, which seems to be getting worse in COVID, building connection and safety. Meeting basic human needs is something that we, it seems obvious to say, but people still don't have housing. People still don't have food. People still don't have what they need to take care of, pay for a phone, for example. And how can we ensure people are using safe substances alone or in combination? We know that polysubstance use is the norm. People are not, just using one substance. And so I think trying to understand that and trying to think about, okay, people are definitely using multiple substances. How do we keep people safe and make sure that they're having safe and copacetic kind of experiences that they want? I feel like the psychedelic community is very interested in, like, we could learn from the psychedelic community. They're very interested in like creating like a good experience, and like how do we understand that people are using drugs to have good experiences? How do we address structural racism in harm reduction in treatment centers? How do we increase access to life-saving medications? So these medications that we have, they're locked up. There's waiting lists. It's still, people are still kicked off of methadone and buprenorphine. People still have to wait 2 weeks. People have to pay cash for so there's so many different ways that these medications that are highly effective are locked up and kept away from people who need them. Intervening on stigma and shame, intervening on the carceral footprint of police, jail, family regulation systems, child protective services, supporting and engaging people who use drugs in advocacy, centralizing their voices, and supporting people who use drugs and people who engage in sex work and achieving their goals. So that's some of what I am worried about. Other questions I have. How can we hack these outdated buprenorphine and methadone regulations and expand access now? Low dose initiation, freeing methadone from the clinic, liberating it to a pharmacy, or liberating it to other kinds of primary care models. How to increase access to naloxone for people who are currently in this naloxone shortage. Thinking about a safe supply. Really, I do feel like when I tell my patients to go out and use like a fentanyl test strip or to use naloxone, that I'm relegating them to play Russian roulette. Like I literally am asking them to go out and play Russian roulette, and that is unacceptable. Like it's terrifying for me and for them. And so I really feel like safe supply is where we need to be. I would love to be headed there. How can people afford and access harm reduction equipment and supplies, particular concerns of youth and aging people? There are a lot of aging people who are using drugs. There are a lot of people in their 60s and 70s that are using drugs. And so I think it's a unique population. I think it's a growing population, and there are certainly have medical frailty and increased risk for morbidity and mortality already. And so I'm definitely worried about them. Keeping our LGBT, transgender, non-conforming folks safe and thriving, and how to create sociocultural systems and discourses that allow for people who use drugs to acknowledge that people use drugs for pleasure, exploration, and growth. So I actually read a member of Drug Policy Alliance wrote she got sick with COVID, but she wrote an article at the time of COVID that was like, we really have a discourse for white people that's completely different from Black people. And white people are allowed to consume cannabis in their dispensaries, and they have all of their Peloton for wine and like cannabis curated, mommy groups. And for Black mothers, it's like they do not feel safe. They do not feel supported. They're surveilled. Their children are taken away. They're put on the federal registry if cases are called on them. In New York State, for example, the federal registry or the state registry, state central registry, if someone charges you or calls the state about a concern of neglect or abuse on you, and that charge is investigated, your name exists on the registry every time you're applying for a job and housing until your oldest child is like 28 or 25. Like that is a hugely structurally racist system that, people wrote articles that were like, stop the registry, because this is literally like a very structurally racist system. And then treating pain, for people with and without SUD. And pain is obviously a topic of considerable interest, but from my point of view, really, how do we comprehensively treat pain, whether it's with opioids or not, for people who need it? And I think that mentioning pain is really important because it does overlap in many ways with what we do. And I'll just say that I put some images of people that we've lost in the last year. Michael K. Williams, who is an actor, a very acclaimed actor that many people knew from The Wire, from Omar Little. He died of an accidental, it's always called accidental, but he died of an opioid and cocaine, fentanyl overdose. Jason Crowell, who was a harm reduction worker in New Haven at Sex Workers and Allies Network. He died about a month ago of an opioid overdose, and he was working very hard on getting an overdose prevention center in the area, and that was his kind of life's work and passion. And I was also talking to people who were like, in the harm reduction community, we didn't even know people were using, and like, we are the people who want to like, please tell us, you know what I mean? And so like, what is the process where we keep losing our own people? That's like a particular problem that keeps me up at night, which is like, we should have the tools, the safe space, the connection, the community to support our own people who are using. So what does it mean for us to keep losing our own people? And Dylan Stanley, who, this is a picture from St. Louis where Jody and I last met, but she died of an overdose. And she really spoke very publicly. She was a harm reduction worker in Ohio. And she spoke very eloquently about the way that Child Protective Services really made her life like a living hell, basically. And she was cycled kind of in and out of different kinds of treatment programs. She was really distraught by sort of the way that the systems treated her, including the CPS system, but also just the treatment systems. And she really struggled. And ultimately, I think after this picture, she died maybe 6 months later. So this is, I end on this note because like, these are our friends, our patients, our neighbors, like, these are wonderful people. And the tragedy of it is that we have the resources, we have the intelligence, we got vaccines for COVID in like less than a year. Like, how did that happen? And yet we still can't really hack these problems where people that are so brilliant and have so much to contribute to our society are really subject to premature death, and these are, I think, where I hope that we can hack that this weekend. So I'll end with that, and thank you for all your work today and this weekend.
You actually, could you stay there? That would be wonderful. With our setup is that I have a microphone if people have questions for Kim who are here, and we do have some questions from people on the live feed and Q&A. So I'm just actually going to read those.
Great.
And Brandon, I don't know if you want.
Articles published on the fact that people who use drugs feel like our healthcare systems feel like jail. They feel like they are that the slide where I showed you autonomy, and people have no autonomy. So people feel like it's jail and prison. I was taking care of a patient who was hospitalized for 6 weeks of antibiotics for endocarditis, and she left many times because she just was subject to a lot of surveillance. Her visitors were restricted. She had a PICC line, which meant, and they were like, okay, well, with her PICC line, if she leaves, we can't let her have her regular clothes. We have to put her in like a yellow gown to flag that she has a PICC line. So it was almost like they were creating this exceptional costume for her to wear that like they didn't afford her. She was literally like living there for 6 weeks, and they didn't really afford her any of like the basic decencies that we would have wanted for ourselves to wear our own clothes. So I think there's many things that we can do. I think it's very interesting too to think about, like when I was in Boston, there was a hospital called the Faulkner, and they had like a special wing that was dedicated to treating addiction. It was like a level 4 detox, and they had special nurses that like cared for addiction. And so in every hospital I'm in, we're like, oh, we should like really create that. Like, wouldn't that be great? But at the same time, like the worry is like that creates, stigma, and we really need to train everyone up to care for people who use drugs. I mean, it has to do with our larger cultural discourse in which we're steeped, which is to hate and disbelieve, distrust, dislike, and think people are bad who use drugs. Like we have to unlearn that. Like that is something that we all are steeped in, and we have to unlearn that, actively unlearn that, because everyone has, some of these beliefs. And so I think we get that from media, we get that from language, we get that from, all TV, we get that from all of these depictions. So all that to say is there's a lot of practical things you can do. You can have like messaging that says like drug user friendly, or like we accept you for these things. And you can have a lot of signage. You can have things in your way. For example, like there's waiting rooms at Bridge Clinic at Mass General that have, like safe supply, like safe equipment that people can access, right? I mean, having things that are welcoming, like things that people want and need. I know that like every time that I would talk to some people in my book who came to the hospital, they would literally take everything out of the drawers because they literally had nothing, they had no towels, they really wanted to like have all of the towels and things like that. Like they needed things. And so I think there are ways we can be much, much more welcoming and accommodating in our clinical spaces. And then getting out of our clinical spaces, like I mentioned before, is really even more important. So getting to under the bridge, going to the encampments, like really, really meeting people where they're at, I think is critical. And that is humanizing. And that is where I think we need to go. I think the next level of care needs to be like, how do we mobilize, liberate people from the clinic, so to speak? How do we bring the clinic to the people? How do we have models where we, street medicine teams where we go out and we have HIV meds, or you need antibiotics, I have a Zithro, or you need this, like, how do we need those scaled up, or you need methadone, or you need whatever, like, how could we do that? Like, how could I put on a backpack and have 20 essential meds and take care of you? And how could I prevent you from having to go through? Many times when I was training at MGH, I'd be like, okay, so you have to be admitted, you have to go through the gauntlet of the ER, you have to wait 30 hours, you have to go because you have, these conditions, X, Y, Z, we have to do this in the hospital, but maybe I didn't have to do it in the hospital. Maybe I could have done it at her house. Like how could I have brought it to her? So like, there's a lot of things I think that we could do more of.
There's a question, I'll just read it aloud. This person asks, I understand harm reduction as a true ecosystem of systemic and person-centered supports, and the data seems to support that too. How do we bridge the gap between the extensive data about behavioral health and substance use and resources and the institutions that seem to refuse to hear or internalize it? Bridging the gap.
Bridging the gap, okay, between evidence of harm reduction and our institutions
That refuse to hear it.
I think this is where stories of narratives really are critical. Like people telling stories of people who are alive and thriving because of harm reduction. I mean, I find them, New York City had a campaign that was like, naloxone saved my life, or like, I naloxone my best friend. And it was really powerful. They used real people, they used real stories of like, I'm alive because someone gave me naloxone, and they're wonderful. Like they're real, and they have like a little vignette, and they were really humanizing. So I think public health departments, I think really that this idea of that, that Brandon mentioned of hope, like how people are resilient, people are creative, people are wonderful, and like really do often, get to places where their substance use is stable, where it's minimized, where the harms are minimized, where they're able to use them safely and live the kinds of quality of life that they want. I think people don't believe it. And there's this whole campaign I mean, there, Ingrid Walker, who's a professor at University of Washington, and Carl Hart, and a bunch of other people are trying to say, like, look, I use drugs. Like, I use drugs. Ingrid Walker, is like, I'm a professor, I use drugs. Carl Hart's like, I'm a professor, I use drugs. And I always tell the story of William Halsted, one of the founding fathers of modern medicine, the surgeon who created, some of the initial techniques for breast cancer. Antiseptic technique is related to Halsted. He was a very chaotically morphine and cocaine, user throughout the time that he did surgery and throughout the time that he contributed immensely to founding the pillars of like medicine. So like, if we believe that people who use drugs are worthwhile, despite or in spite of, or whether they are and are not using substances, and that they can be productive and create, contribute meaningfully and deserve to live and deserve to have freedom and autonomy, like those stories need to be told. So I find that really compelling, the argument being like, we should talk about substance, like people who are privileged need to talk about substance use in order to just say like, I use whatever illicit drug, and to sort of destigmatize our deeply ingrained notions of like what it means to be like a heroin user, et cetera, like that, and to shake up in our minds, because I think that people persistently think that it's a negative thing, or that people have problems, or that they can't be functional, and we know those not to be true.
Great. I'll actually ask the members of the audience if you have any questions you'd like to ask this time. I might have to ask you, since I have moderator's purview. I was seeing that you did have a request for a boat, for a SIF boat.
Yes. Okay. Yes. Mm-hmm.
But to follow on that question, the state of Rhode Island is undertaking regulations and thinking about harm reduction centers. What are your thoughts about mobile? Mobile has expanded so greatly in the time of COVID, and mobile health units. Backpack exchanges, part of our bread and butter syringe service program access here. What are your thoughts about smaller programs that might be more mobile for harm reduction efforts like a safe consumption space? Yeah,
I think mobile is wonderful. Like, I think it could be, in many ways it's cheaper, it's nimble to kind of overdose hotspots. You solve the problem of, you don't solve the problem of NIMBYism per se, but you diffuse it. I think having, Brandon and I were talking about having multiple operators. And I think having, I think that also will increase like the range of services might be different, the approaches. Some prevention, overdose prevention sites in Vancouver are women only. I mean, there's a wide variety. It gives you, I think, an ability to be more nimble and to really seeing how people use drugs. I think seeing if you could design it for the way that could enhance how people actually use drugs. So one example that I would say is I was in Vancouver, and they were like, oh yeah, we had these like individual booths, but a lot of people use drugs in twos, like really like run with people, and like inject people inject them, and they check on each other, and they're using together, and they're kind of, so they realized like these booths, like really two people wanted to sit at the booth, so I think it's really important to figure out how do we create spaces that are informed and designed by, led by people who use drugs. Like, how could we envision a van? Where would they want to use on this? Like, if I had this tricked out van that had like a bathroom and like a clinic space, like, like some like a clinical van, like where would people want to use on that van? Or like, in what context and when, like, should the van be, open at, the peak times, which are, in Connecticut, they're often like nights, and they increase, the overdoses increase like Thursday, Friday, they kind of increase at the end of the week. So like that does, I think, allow you to be a little bit more nimble. than having a fixed site with a lot of costs. And St. Anne's Corner of Harm Reduction in the Bronx, where I saw patients in New York, they really wanted to be a site, and they wanted to have a pharmacy. They already were going to be 24 hours drop-in, but it comes with a lot of staffing. It comes with a lot of overhead, I think, to have a fixed site. And certainly they were already positioned to be it because they were already an SSP, and the neighborhood kind of knew them already, and the same people, came already. But I think it also prevents the problem of, like, I don't even know if you call it like a honeypot, but it diffuses, like, substance use is happening in many areas. I think also thinking about if someone's going to go use a spot, like how far will they travel to go use a spot, and like if they're in opioid withdrawal, like, are they going to travel? Would I walk 4 blocks? Would I walk a mile? How far from where I procure drugs would I want to go to use them? And then also the problem of, this is not one of my problems, but like the public health problem that many of you care about in this room is of people using alone, at home. How do we make those places safe? Like if I was, I really think that is, many people want to do it in the privacy of their home. Many people, that's convenient, private, for them feels safe. And how do we make that as safe as possible?
Uh-oh, you have one more question. Yeah, let me take.
Thank you so much for all your insights and sharing your experience. I just had a question. I was hoping that you could speak to all the hackers as to the central role of mental health and trauma patients. I'm saying patients, I'm a clinician, sorry, and people who have substance use disorders. Are there hacks that you think are there for the taking that deal with trauma and mental health?
That's a good question. As I think you're inferring also that, it's very common. I think thinking about some of the hacks that I might have. I think sometimes in the hospital, I see a lot of patients who come in with, let's say, a mental health crisis, suicidal ideation, or a suicide attempt because of chaotic substance use. And they're not necessarily saying like, I want to die, but they're saying like, I need help. I'm at a place where like, I can't maintain anymore. And so I think trying to figure out how we can provide those supports and get those supports to people before they end up in the emergency room would be great. I think, I would wonder if there's a way to set people up with peers, like if there's a way that you could hack people with lived experience being the front line of sort of crisis intervention and de-escalation, and ways that people could, I know there's a lot of crisis hotlines, there's like a lot of suicide hotlines, for example, but I think specifically for people who have lived experience of substance use is a particular subset. Of, let's say, people who are having a crisis leading to suicidal ideation. So I would think trying to get peers involved, trying to have sort of nimble teams of clinicians. Even the problem of people who are having a mental health or substance use crisis and get killed by police. So how do we hack that problem? And I was on the phone with someone yesterday who was like, are there models of other programs around the country that are nimble to responding to someone, who's chaotically using meth, who's waving like a sword, and like how could you envision a hack where that person doesn't get killed by the police? Because that would be great, because that's often a system of, it's often a structurally racist system. It ends up being it has a lot of implications for people that are really in like a temporary state that might be caused from drugs, or and how do we envision a different system? How could we envision a different 911? How could that get triaged differently? How could that get handled differently? Who could go out and handle that? Who feels equipped to handle that? what level of, I was talking to this person and I was like, well, I mean, some people would feel comfortable running into a room with someone on meth. There's some harm reduction programs that have these like there's meth sobering centers, for example, in San Francisco and the West Coast, where people just, go hang out and, and the people who run those feel very comfortable with people who might be having psychological symptoms of meth, like paranoia, psychosis, auditory or visual hallucinations. Like, what level of training do you need to feel comfortable with that? And I'm like, harm reduction centers are like a wonderful space to like prevent people from being killed by the police for like acting erratically. And so like that is maybe one hack, but like what are other hacks we could do?
We have time for one more question, and then we're going to take a break. This question, it's coming in through the feed. The question, street medicine is so vital, but qualified doctors are already burnt out, and getting the number of people to meet the need to do outreach at camps doesn't seem possible. As harm reductionists that have a history of operating in gray area to help people, what can we do?
They're trying to, all of these questions are like, these are questions for you. Like, these are like, I don't know the answer to these questions. I mean, I think there should be, okay, so that's multiple questions, actually. It's a question of, I think, burnout. It's a question of supply. It's a question of re-envisioning care models. I think having allied practitioners who aren't doctors is essential. I really don't care if someone's a peer or an RN or APRN or a PA. And I really think we need to do a better job of training allied health professionals. I think burnout is a real issue. I think the issue that I mentioned about trauma and grief, it does affect us as clinicians as well. And there is some secondary trauma from having your patients die in their 20s, 30s, 40s. Like that is like, it is a hard field. And I was talking to some potential applicants for the addiction medicine program at Yale. And they're like, oh yeah, I just really like click with people, I just love talking to people who use drugs. They're just so real, et cetera, et cetera. And I'm like, I love that. It's great, but it's like a very tragic field to go into. Like it's a field where, like basically people our age, younger than us, people die like ahead of their time. Like, and we really, I don't think have, healthy systems of processing that. And so we're trying to kind of create communities or create groups where people can process that and continue their work, because it does feel really crushing. It feels very like Sisyphean to be rolling a boulder up and down the hill every time and trying to just, like, I feel crushed by it when people just call people abusers and, all this like terrible stuff. And like, so I do think that doesn't really necessarily solve the question, but I think trying to, street medicine is wonderful. I think it probably also has to do with, getting more funding for it, really publicizing it, really making it sustainable, really making sure that it's able to be sustained in clinic settings, and that clinics and programs are able to keep them up, and that they're seen as investments, that your community will invest in one, and that it'll pay dividends. So.
Valuing harm reduction. Love it. Thank you for all of these great ideas, hacks, challenges, and otherwise. We'll take a break. Thank you.